Hi guys, we're just waiting a couple of minutes before we get started. Just giving people a chance to log on and then we'll get going. So we've just got a few people logging on. So if you're joining us, welcome, and we'll get started in just 1 minute. Perfect. Okay, let's get going then. So hi everyone and welcome to our first webinar of the year. Tonight's webinar is Shockwave, Translating Research into Practice for the Upper Limb. So I'm Katie and I'm the Training and Education Manager here at PhysiQuip. PhysiQuip, for those who don't know, provide evidence-based medical technology, training and education. So tonight I'm joined by our very own clinical application specialist, Dominic Smith. So Dom's role here is to provide training, treatment and consultancy for the application of specialist equipment that PhysiQuip provide. So Dom is going to talk to us this evening about breaking down the research available for focused shockwave for the upper limb. So the format of the webinar will be a presentation from Dom, followed by a few questions after. So if you'd like to submit a question at any time, please use the Q&A section, which you can find on the bottom tab. So let's get going and I can hand over to Dom now to start the presentation.
Thank you very much, Katie. Hello, everybody. I'm quite happy to be kicking off the webinar series this year for PhysiQuip. So I hope it's a good start to the series that we're doing. So as Katie said, we're going to be talking about research and translating that into practice for the upper limb. So let's have a quick look at what we're just going to cover through this session. So we're going to have a look at the different variations of shockwave. So you all have a bit of background on the different types of technologies that are available to us. Then we're going to review some upper limb indications for shockwave for each of the major joints. We're going to look at shoulder, elbow and wrist. Obviously, we're not going to have time to cover everything, but hopefully it will just give you a good idea of what different applications you've got. We're going to have a couple of examples of research. We're not going to delve too heavy into that, but we're going to have a look at each one, what information we can take out and how we can put that into practice. We're also going to discuss variables and treatments, so frequency, intensity, sessions per week, and also looking at prescriptive treatments versus a personalized treatment, and just touching on the differences there and opinions on that as well. So the purpose of this presentation, so Katie's might mentioned already, is that I'm a graduate sport exercise therapist. So one of my jobs at PhysiQuip is, when we look at all of the equipment, is that I read a lot of the research, trying to speak to all the clinical experts, people who use the technology from the UK, but around the world, to try and get their opinions basically, and just find out the facts about this system. So really the purpose is to educate you a little bit more on what is available to you, but also the challenges that you might face if you're looking into shockwave. So if you're very new to shockwave, it's something you're really interested in looking into. So hopefully this should give you a bit of insight of what is to come, and hopefully not scare you, but should make everything a little bit easier. If you're currently using shockwave, then hopefully it might just answer a couple of questions that you've had that's been burning away for the past however long you've had the system. And the other purpose is to just cut through the BS with it all. So obviously I work for PhysiQuip, I work with a particular technology, so there is a level of bias there, but I'm going to be as objective as I can, as honest as I can as a clinician, for what I've read, what I've seen, and the experiences that I've had in practice using shockwave technology. So that's going to be the purpose of the session today. So a little bit of background. I'm not going to go too heavy into the science. So if you're familiar with shockwave already, this will all be very familiar. So we know that a shockwave, a definition, is a strong pressure wave in any elastic medium, such as air, water, or solid substance, that creates a violent change in pressure. That image on the bottom right there, that is your typical shockwave pressure profile, which is a short, abrupt amount of pressure. And if we actually break that down into some specifics, we know it's a single pulse width. It's a very high pressure amplitude, low tensile wave, which is this aspect here, but just drops below in that negative pressure phase. It's a very, very small pulse width and a very short rise time. So that is your typical pressure profile of a shockwave. Now, depending on which system you use, those pressures could be higher, could be lower. It's going to depend on each system and the way it produces the shockwave, which we're going to touch on in a second. And you'll know it as extracorporeal shockwave therapy. So if you see ESWT through the slides, you'll know what it means. So generation of shock, or generating a shockwave, how is it done? So there is different technologies out there on the market. You've got electromagnetic, electrohydraulic, and piezoelectric. And they're the different principles that can produce a shockwave or a true shockwave. Now, these methods can be categorized into two areas: direct or indirect production of shockwave. Now, each of these systems, the consistencies that they have is that they all have a therapy source which produces the energy, and it is coupled by a flexible coupling piece, which is usually a gel pad. We've then got a coupling medium, which is either water or a water-based gel that couples the therapy source to your patient, and that allows the pressure wave to travel through. Now, if we look at this into a little bit more specific, so this is your electromagnetic principle. And you can see here on the diagram on the right, the energy is emitted by a flat coil at the center of the therapy source. That energy then transfers out, hits a reflector dome, and then bounces back in to create this, what we call a focal zone here, which I'll just explain in a couple of slides. And that is where your shockwave takes place. And then you also have electrohydraulic. So this is generated instead by a spark plug rather than that magnetic coil. And again, these propagate through water that hits what we call a parabolic mirror, which then again bounces into that focal point to create your shockwave. So those two are what we call indirect focused shockwave. Reason indirect, because we're bouncing it to create that shockwave focal zone. You've got the piezoelectric principle, which is the only direct system that you have. So the reason it's direct is you can see where the piezoelectric crystals are arranged in the therapy source in the dome. You have an electrical current that goes through the cable. Those crystals expand and contract, sends a pressure wave through, which then travels again into that focal zone. You've got two different types, single layer, double layer. All that basically means the double layer is more powerful and can travel a lot deeper. So that's what we mean. That's what we mean the differences between indirect and direct. I mentioned the focal zone a couple of times. So when a shockwave produced, this is your point of delivery. So if you just look at this diagram here, your patient won't feel any of the energy waves as they are converging. Once they converge, that's where you get that focal zone of energy. And that is where your shockwave takes place. Depending on the system, the size is going to be very different. Some are around about 10 millimeters in height by 2.5 millimeters in width. Some are 30 to 40 millimeters or 3 to 4 centimeters in height. Generally speaking, the smaller it is, the more accurate you're being, and the more homogeneous, the more reproducible the energy is per shock. Depending on who you speak to, you might get a different answer on that. So when you're looking at those, if you're looking at specific devices, I'd just ask the question, what the energy levels, what's the size of the focal zone, so you have a good idea of what that device is actually producing. It's important to note that true shockwave technologies can adjust the depth, angle, intensity of this focal area. The angle is essentially you just altering where the therapy source is, and the depth can be often controlled by the gel pad. So you can precisely control the exact point where the injury is, so you can hit that exactly. And one thing I want to touch on as well is the linear shockwave therapy source. So this is unique to the piezoelectric principle. So where we just talked about that focal zone, which is about 1 centimeter in height, 2.5 millimeters in width. What the linear does is it lines 5 of those up in a row, and that creates a band of shockwave. And that's a really nice bridge between radial and focused. So we'll touch on radial in a second, which is it treats quite a large area. But what you get, the benefits of this system is, or that's therapy source even, is that you get 46 millimeters, 4.5 centimeters length of shockwave. So you can treat a larger area still, but still getting the physiological benefits of focused shockwave. And again, that's a direct focused for you there. So I mentioned radial, and I think it's fair we have to mention radial on this because this is part of the shockwave therapy market out there. You'll hear people calling it radial pressure wave, which is if you're looking scientifically, that's kind of the true aspect of it. However, we all call it radial shockwave. It's widely accepted as radial shockwave. It's a very good system. How this produces, you have a projectile inside the therapy source that goes backwards and forwards. That creates the energy that comes out of the therapy source, hits the tissue, and then the energy propagates out. It's essentially the reverse of focus, whereas focus directs the energy inwards, radial directly outwards. So the next image here will give you a good representation of how the two differ. So radial is effective to about 2-3 centimeters. If you press harder, you can get a little bit deeper. If you increase the energies, you can get a little bit deeper, but it's very difficult to measure and monitor that. However, focused is you can control that from 0 millimeters to 60 millimeters. I know that systems do go down to 10 to 12 centimeters in depth as well. So you can get very, very deep with those and very precise. So in summary, I mean, that's a whistle-stop tour of the variations of Shockwave for you there. So there's loads of different variations of how a shockwave is generated, how those energies are generated, and they all differ in many respects. So if you are looking at systems, it's really important to get as much information as you can from the manufacturers, but also colleagues and peers who use the technology as well. It's important to know as well and understand what type of shockwave you have in clinic. So if you do have a shockwave in clinic, make sure you know exactly which it is. As quite often I speak to quite a few clinics and I, what shockwave do you have? Like, oh, I'm not so sure. And it's really important that you know the difference between radial and focus. There are categorical differences between them. But if you are looking at shockwave, these are just some things that I've pulled together with other clinicians of what they think is the important aspects to look for in a shockwave device. So durability, efficiency, energy levels produced. By that we mean how low can it go? How high is it? What is the energy range that you get? Is it quite limited range or does it give you quite an extensive range? Focal zone size, we talk generally the smaller the better. Relationship between frequency and intensity, what we mean is by this is as you increase frequency, the intensity has to come down or vice versa. You're not necessarily be able to max them both. And then also depth control, I think that's a big one for me, is whether you're wanting to hit proximal hamstring or patella tendon, or something in the mid muscle belly, is if you have that precision of control in terms of the depth, you know you're hitting the right point. In terms of how shockwave works, that's a chat for another day. We do have the content around that, and I've done a lot of reading around that and pulled all that information into a document. So if you are interested in learning a little bit more in how particularly focused shockwave is stimulating tissue healing and the physiological response of shockwave, then when we send out the survey at the end, if register your interest, and then we can get that information out to you. So now we've got a bit of background on shockwave and we're up to date and up to speed on what devices we've got available. We're going to talk about the research. Now, the challenges that we face with research, and this is, in my opinion, I think these are the challenges that we face. The amount of papers that they're available to us over the last 30 to 40 years is insane. It's a huge amount and can be quite overwhelming. And it covers many, many indications as well. So, you can type it into PubMed, you can get absolutely loads. So how do you know which are the good ones to read, what are going to be the highest impact and things like that? Also consistency. Over the first lockdown period, I spent a lot of time reading some papers, and the inconsistency, should I say, between some studies, and that's the study design, inclusion, exclusion criteria. Some didn't have a control group. Some didn't tell you which shockwave system they were using. Some only had one session as an intervention. Some had 4. It was very quite confusing as to what the actual design was. And we'll delve into that a little bit towards the end as to why they might be so different. But then also credibility. Some papers, like I've just mentioned, don't tell you actually which shockwave system they're using. And like we've mentioned before, there are 3 different types of focus. There's also radial in there as well. So, and it's also important, there's quite a few papers that I've seen that were sponsored by particular manufacturers. And obviously some of the researchers had some form of involvement with the manufacturers. So it's always really important just to have a look at what potential biases there are. There's a load of papers out there. And all of these points leads to contradictory evidence and even more confusion, which I'm sure if people are familiar with shockwave, I hope you probably agree with me on that, because you can read some papers that say that waxing lyrical about how good it is for a particular indication, and you'll read another paper that will just say no. And then you're sat in the middle as a clinician going, well, I don't know. The safe bet to start, and a good starting place, is have a look at the review papers. And then the papers that they're reviewing, any that have that they particularly go into, then you can kind of go down those kind of routes and look at the individual papers. I will point out, though, that again, the review papers don't often differentiate between focused and radial. They bundle it all in together. However, when you're reading them, they do actually differentiate during the paper, but it's not one particular thing. So I hope that gives you an idea of what you might face if you're looking into the research anyway. So quick warning, there are some busy slides ahead, so bear with me. if we're done with it, once we're done with this webinar, if you want the references, we've got the reference list so we can send you them. You've got the recording as well. So once the recording's released, you get that link, you can just go back, pause it, get the reference and then find it for you and you can read it for yourself. But really this is just opportunity of just handpicked a couple of papers and taken them and then summarized them into how we could potentially put that into practice. And just from here on out, if I'm talking about shockwave, I'm referring to focused shockwave. So first and foremost, shoulder indication. So typical indication, shoulder calcific tendinopathy is pretty much our big one where shockwave is concerned. And we've got also subacromial pain syndrome or impingements, which seems to be quite commonly used. Other indications where it's commonly used, ACJ ligaments, where you've got any ligament problems in and around the shoulder, a frozen shoulder as well. In terms of bone, I think it's, we were talking about this earlier, there are indications for bone, but mainly go through fracture clinics or consultants, but it's still worth knowing about. So there are people that I've seen and heard that do it with labral tears, delayed union and non-union as well. There's really strong evidence for that. Arthritis, there are some people using it and there's some papers using it, but evidence is not quite there yet. I think it's more from a pain management perspective, but we'll go from there. So I want to look at shoulder calcific tendinopathy because that is the big one. So I've pulled 3 papers here. So 99 paper, and you can see here 2 shockwave sessions, 2,000 pulses, 0.3 millijoules, and then a sort of a control group looking at 1 session, 2,000 impulses again, but a much lower dose. And they showed that the higher doses showed more efficacy than lower. Again, in here, we looked at high energy groups, so 2 lots of 1,000 impulses at 0.5 millijoules, only a small group with this. But again, among the shockwave patients, they showed that calcium deposits were completely eliminated in 7 cases and partially eliminated in 11, whereas in the control group, they didn't show any changes. And then finally, we have this one, so a few more patients, 46 patients, high dose and low dose. And then calcific deposits disappeared in the same percentage of both patient groups. So quite interesting, but the main areas that I'm more interested in here without delving into too much information is the actual intervention and what we can take from this as to, and the conclusions that they've made of how we can translate that into our practice. So if I'm looking at all of the different research papers that I've read, like several studies have found very, very good correlation between the applied energy of each shockwave in comparison to disintegration, assuming that the shockwave is carefully focused. So, excuse me, you'll hear that a lot, particularly for calcific deposits, if you have access to diagnostic ultrasound or some form of imaging to identify the depth and the size and the location of those deposits, that is pretty much your best port of call. If you're doing it almost blind, it's almost like a blind injection. Sometimes you hit, sometimes you miss. Whereas if you have that image, you're going to hit and your treatment outcome is going to be much better. It is, however, still unclear of which parameters of shockwave relate to the most absorption of the deposit. So we use energy flux density, so millimeters millijoule squared is the energy flux density as the primary parameter. But when we're looking at the average application, and this is including those 3 that we've just covered then, but also in the other papers that I've read, average impulses per session is between 2,000 to 3,000, at around about 2 to 5 shocks a second, between 0.1 and 0.3 millijoules. Some would go higher, but then between 2 or 4 treatment sessions. That's the average. Now we'll point out on these when we put an example application. This is an example. So if you do have shockwave and you're looking at this, it's really important to still clinically assess and select the appropriate treatment for your patient. Also, depending on who you speak to and depending on your clinical experience, that might be quite different depending on what you want, but this is just what we're translating from the research. So to briefly summarize, it's definitely an efficacious therapy for calcific tendinopathy of the shoulder. Its effects are dose dependent. However, it helps with functionality, pain, and reabsorption for calcific deposits. Particularly, the reabsorption is happening with much higher doses or higher energy doses, so 0.3 millijoules and up. Now, it's important to note that often the pain reduction usually happens before the radiographic changes, showing any deposit changes. So we always get the question of, do you see the calcific changes? I've got little experience because I don't scan. However, speaking to others, some see it within 3 to 6 months. It might take a little bit longer. But obviously, as clinicians, if we can help people with pain and improve their function, that's a big tick. And then as we see those changes and the reabsorption, that's again another big tick. And it's also, for tendinopathy perspective, there are some really good papers that suggest that Shockwave induces neovascularization at the tendon junction, which releases growth factor and other proliferating factors as well, which leads to tissue healing. And that's a big part of it. We're stimulating new blood vessel growth, which is going to be better tissue healing and regeneration. So again, if you're interested in those papers, we can source those for you. I want to touch on the non-calcific tendinopathy. So unlike calcific, this is quite a controversial area. There's been some studies on this that have had encouraging results, but others that have had poor outcomes. And this can be, and what we're talking about before, some of the challenges that we face with some of these papers, is there's wide age ranges, a completely really diverse population, and there was not very good diagnostic evaluations either. They were also including different types of sort of pain. So subacromial pain, non-specific shoulder pain as a diagnosis. So they weren't being very, very specific with some of these papers. And that's been, again, reflected in the review papers as well quite recently. Some of it may have changed but recently, but, you know, from my recent reading, I've not seen much change with the non-calcific. So shoulder covered, going flying through this real quick. So elbow indications, typical indications, you know, tennis golfer's elbow, that's pretty much the big one. As soon as you see Shockwave, tennis golfer's elbow are pretty much top on the top of the list. Other indications you can look at, I've seen people and I've seen research looking at bursitis, but also collateral ligament sprains, maybe even repairs as well, following any major traumas. And again, I want to touch on the bone and articular indications, so stress fractures, delayed unions, non-unions, good evidence there as well. But on this, I think it's only fair that we concentrate on that particular tennis elbow. So this is 100 patients, so a really good sample size. They had a low energy and then a control group. So low energy, one lot of 3,000 impulses, 0.08 millijoules. And then the control, very, very little in terms of their dose. Only 30 impulses is not going to make much of a difference. Then we looked at, I would say we looked, the authors looked at 24 weeks, showed really good improvements in the Shockwave group, but very little improvement in the control. Overall, they found it was successful, but it does warrant further study to look at the most efficient method. Next paper, we'll look at 114 patients. So again, another decent sample size. This time we're looking at 3 lots of 2,000 impulses at 0.06. So a little bit lower on the energy, but a lot more in terms of volume at weekly sessions. And then a sham group where they use just basically an energy blocker. And again, 12 weeks improvement in the sham group, but a major improvement in the Shockwave group. And it resulted that a low dose Shockwave therapy without anesthetic, which I think is quite an important thing, is it's manageable from pain, it's safe and effective. So in terms of translating some of that research, now it's only 2 papers, but, you know, again, looking at some of the papers that I've read, there were quite a few different variances in terms, so you see there 1 session at 3,000, 3 sessions at 2,000, slightly different energy levels. So again, these challenges we face, but pulling that, impulses per session, anywhere between 1,000 to 3,000. I think that you're going to be looking at how your patient is responding. 2 to 5 impulses per second. Now, again, depending on the papers, it was 0.08 to 0.2. Some papers were suggesting much higher energy levels, and again, 2 to 4 treatment sessions. And I think the really key point is, because we're around that bony area, particularly with Shockwave, it can be quite uncomfortable. So you want to avoid any strong pain sensations and make sure you keep it within the realms of tolerance, and you want to alter the energy levels where appropriate for those patients. So in summary, there have been ample studies in this area, yet, you know, depending on who you speak to, it's still a little bit of a controversial area on its effectiveness. I clinically have had some very good results. On the flip side, I've also had some patients that haven't responded whatsoever. There are other variables, like they might not do their exercise rehabs, they might be resting as they should be, and anything else. So if it doesn't necessarily work with Shockwave, that's where we might look at different alternatives. But again, these are different discrepancies that we see in the literature. So duration of disorder, type frequencies, timings of follow-ups, and the outcomes assessed as well. That was another thing, it sort of pops in now, is that a lot of the outcome measures that you look at, if they don't have the radiographic aspect, they're very subjective. They're using VAS scores or constant Murley scores. So quite a lot of subjective outcomes as well. Despite that, it is an FDA approved treatment for tennis elbows. Shockwave is FDA approved, and it's the same with, I believe it's on NICE as well. So despite there being a lot of controversies, the big groups are approving it. And this is down to the fact that the benefits are far outweighing the potential harm. So again, it comes down to if you can clinically reason, you can clinically justify, and you know it's safe to use for that patient, and all of the conservative treatments have failed up to that point, then it is certainly something that you can try. And moving finally to the hand and the wrist, so typical indications for this area. Now, if you've not tried it on the hand and wrist before, this might be quite an interesting one. I've tried it a few times. Also worked with a couple of boxing groups that have tried it with hands and wrists, and a couple of other clinics that do this as well. So you've got carpal tunnel syndrome, Dupuytren's, de Quervain's, trigger finger tendonitis, also ligament sprains again, volar plate injury, and again around non-unions, delayed unions, fractures. We've also put in like post-tendon repair. It would be when the repair is well set and pretty much well healed, where you're wanting to stimulate better generation. Again, that's an area for debate as to when you would use that. There's not many papers, if any papers, around that area, but still one that might be worth considering with the right assessments. Let's look at a couple of papers. So this is looking at Shockwave versus the local steroid injection. 36 patients, and we looked at, the authors looked at one session with 1,000 impulses, and it was looking at a maximum energy tolerance. So this was the tolerance of the patient, which was anywhere between 0.09 millijoules, quite a low energy dose, to 0.29, which is quite a high dose, versus just one lot of steroid injections. Again, you see here from this aspect, it's a subjective assessment from these authors. No significant improvement from the nerve conduction parameters. However, in the steroid injection, good improvements there, but still significant reductions in VAS and self-assessment questions as well. So they concluded that it can be as useful as a steroid injection for relieving symptoms of the carpal tunnel syndrome, and it has the merit of being non-invasive. I know there'll probably be some patients that are very nervous about injections. I know I, for one, am not a massive fan of injections. I'll bite my tongue and go through it if I need it. But yeah, it might be a good option, an alternative. And if it works and it means that we can avoid an injection, that's good for you and the patient potentially. So moving on to the next paper, looking at the effects of Shockwave on carpal tunnel again. So this is looking at one lot of Shockwave a week for 4 weeks. So 4 Shockwave sessions at progressive energy levels and doses on each session. So actually progressing that through their treatments. Again, another example of how the study designs completely differ. And then against conservative treatment of just anti-inflammatory drugs, and then a splint as well for the 3 months. So looking at results, looking at nerve conduction parameters, and also the VAS and Levine self-assessments questions as well. We see good results in the Shockwave treatment, and considering the improvement of clinical symptoms from Shockwave without any adverse effects, they've concluded that Shockwave can be applied in conservative treatment for mild to moderate carpal tunnel syndrome. So quite interesting results. I find this quite an interesting area because it's more of a nerve rather than our sort of typical musculoskeletal soft tissue injury. So I do find that's quite an interesting area from that perspective. So if we're translating the research, there are limited studies to pull together for the treatment of this. But looking at the papers that we've got available, it does suggest that lower energies and around patient tolerance is probably the best option for you rather than hitting them too hard, because we know with carpal tunnel, it can be quite sensitive. So an example application, 1 to 3 sessions of 1,000 impulses, and then low energy levels, so 0.05 to 0.1, 2 to 5 impulses again. I've repeated myself there. So 1 to 4 sessions, or 1 to 3 sessions. So a little bit of a repetition. And then again, in summary, if we look about the hypotheses that the researchers that have been pulling together for Shockwave for carpal tunnel syndrome, there is evidence that it's producing nitric oxide in the tissues around the median nerve, which reduces the topical inflammation, thus reducing the pressure on the nerve. And that is the idea of what Shockwave is doing. It's reducing the pressure on the nerve. It's also suggested that Shockwave does have effects on the neural aspects and could be considered as a viable option to manage carpal tunnel syndrome as an alternative to injection, or if an injection fails, maybe it could be an alternative. So yeah, it's a really interesting area if you're looking at the nerve aspect of things. But like I say, there's not many studies in that area. There's still things being developed going forward. So there we go, still more research to be done. So that was a whistle-stop tour on the different types of research that we have for the upper limb and how we can translate that into building a potential treatment plan for your patient. Now, those treatment plans were quite, I think we could call them a little bit prescriptive. We're looking at 3 sessions, 2,000 impulses per session, 0.3 millijoules. So I'm really going to talk here about prescriptive treatments of Shockwave versus a personalized option for you. Now, this is a really strong area for debate, and it really does depend on who you talk to. So I'm going to come at it from as objective as I possibly can. However, it is a little bit, in my opinion, of what my experience has been speaking to lots of other clinicians, but also from my own clinical background. So in terms of prescriptive, I think positives, it's very useful if you're new to Shockwave. The stuff that we do, we have built guideline documents. So, a lot of manufacturers will have them for you. Some have them built into the machines, which can be useful, particularly if you're starting up. It just takes away some of that pressure. You know that it's all set, you know what to do, how to do it. And as you grow in confidence, you can then tweak things. It's also very good for conditions like bone injuries, which are very dose dependent. Again, I mentioned bone injury before. It has to be a specialist site or, backed up with a consultant on that aspect as well. And the other aspect, it gives you a consistent treatment approach for each patient. Everything's going to be consistent that you do. Now, if we look at personalized, the positives there, it's an adaptive treatment approach. You're looking at your patient and delivering a treatment that you feel after your clinical assessment is going to be appropriate for them based on what you've learned with the research, based on what you know with the guidelines, but you're treating the patient for how they're presenting. And then each patient does respond differently to mechanical input. And it's really important to remember that Shockwave is a mechanical input. And the way I try to sort of make sense of this is when you are in a gym and let's say we're squatting, is people are going to be able to lift different weights. Some people are going to be stronger than others. Some people are going to be more powerful. Some are going to be more endurance. Depends on how much weight or how much load you've put on them. And it's a similar kind of principle to this. People will respond differently to mechanical inputs. Depends on what type of activity they do. Are they sedentary? Are they very active? Cyclist, long distance runner, that kind of thing. There's quite a lot of variables that need to take into place. We're moving on to the cons. From a prescriptive perspective, it can be too restrictive, and that can limit your results. If you're doing the same thing for every patient and accepting the same results, we all know the theory for insanity. If you keep doing the same thing and expecting a different result each time, it's not going to happen. So you can limit your outcomes on that. There's also a risk of developing that one-size-fits-all solution, and if it doesn't work for that patient, then it's not your fault. It's that it's maybe the patient wasn't right. The device is fine. Maybe it was something that wasn't right. And also, I think it can become a comfort blanket, which can restrict you as a clinician to explore different variations. And it's, I think it's really important to have those prescriptive elements, but I think it's important to be wary of the potential downfalls that they can have. And then looking at the personalized aspects, you can have too much variation. So it can be very inconsistent between treatments, which can, again, limit results and limit the outcomes for one session to a course of sessions. You might not be providing enough of a dose. You might be providing too much of a dose. So having some form of consistency, I think, is important. And I think when we talk that through, I think we can probably all agree that a mix of the two is probably best where we sit. I think having that prescriptive element for some conditions, and there's a good start point, but allowing yourself to personalize those treatments a little bit, depending on how your patient is responding, is also quite an important thing as well. And finally, I just wanted to touch on what the experts say. So obviously, you know, in the Shockwave world, there are a lot of experts. There are a lot of clinical people that do a lot of training courses and things like that that we see on webinars. Now, I'm not professing to be an expert. However, you know, speaking on Shockwave, it's a very keen area of interest of mine. And I think it's be very wary that when you're speaking to the experts, it depends on who you talk to and what answer you're going to get, and who they work for and which system they use. I think it's really important, and you know, take that from what you will. But I think it's still very important to connect with the experts in the field and connect with your peers that have that experience with Shockwave, whether it be focused or radial. It's very good to ask the questions. You know, don't always take the manufacturer's word for it. Go and double check that from different sources. Find out who the peers are and all that kind of thing. Educating yourself, particularly in this area, is key. I think that goes without saying. So you can make your own clinical decisions, not only in practice, but also, you know, if you're looking at getting a system, you can make an educated decision on which system is right for you. But I still think it's so important to listen to people's thoughts and opinions. Everybody's entitled to their opinion. Doesn't mean they're always right, but you've got to avoid discrediting everything. Take everything on board, and then obviously you can make a decision based on what your experiences are, what you've read, and what you've seen in practice as well. So hopefully some good information there for you to take away. And, you know, if you're reading research papers, how you can take the information out of those papers and put them into practice. We've got a little bit of time for some questions. So I'm going to open Pandora's box, fire away with some questions, and hopefully we can get them answered for you.
Thanks, Don. That was a really informative presentation, and yeah, definitely extremely useful. So as Dom said, we're going to get going with a few questions. Just a reminder for everyone to submit them into the Q&A tab, and we can get them answered for you. So let's just start with a few pre-submitted questions that I have here. The first one, Dom, is what would you say are the main challenges you face when reviewing focused shockwave research?
I think we covered some of it in one of the slides, really. It's just that there's a lot of contradictions at times. You can read one paper that is very positive for using it on a particular indication, and then the next paper you read is not. But I think that's where you've got to delve into it. If you're looking at one paper versus the other, it's looking at, right, what energy levels did they use? How many treatment sessions did they have? How many impulses did they have? What other variables were there? And being able to make that sort of decision, because, you know, a paper, for example, that might have had a negative input might have had a very, very small dose of shockwave, maybe only one treatment session. So from that, you could derive and say, actually, probably not high enough of a dose. So I think there's some really important things. Just because a paper says it doesn't work or didn't show an effect, doesn't mean it's a bad paper. It's giving you an idea of what didn't work, so you know what, or didn't work as well in comparison to another paper. So I think that's really important. It's not looking at the bottom line, the conclusion, it did or it didn't work. It's all right, okay, this didn't show very good results. Why? Why didn't it show good results? I've got this paper that did say, yes, it did, but then this one. And I think it's just having a look at that. And I think that's the only other thing is just look at all the different study designs. It's spending a little bit of time and just picking out where the consistencies are in the study designs. And what I'm looking at is how many impulses they use, what energy levels did they use, frequency, if they tell you, not all tell you what the frequency of shocks that they used, and how many treatment sessions. They're kind of the main parameters that I look at when I'm thinking about how can I actually take that and put that into practice.
Okay, great, thanks for that. And you've covered a lot of recent research papers, but would you say that the research out there is still growing around this area?
Oh yeah, oh yeah. I mean, there's probably more coming out than we can keep up with. So it's like, you know, we've taken some papers that were from like 1999. I think it's good to look at some of the older papers as well, when things were developing, as well as some of the newer papers and the newer literature that's coming out. I always think it's really good. You've got to try and keep up to date as best you can. But, you know, we're looking at specifically at upper limb. Let's not forget we've got lower limb. We've got the bone indications as well. There's quite a lot of areas, and predominantly it focuses around tendinopathy. But the evidence that we have around the the evidence we have available to us around the physiological changes, you can take that across to ligament injury. Like I've treated AITFLs, ATFLs, MCL, you know, after major injuries, surgeries, repairs, and have some really, really, really good results. So, you know, there's some things that we can translate a little bit and move them across indications. But yeah, there's so much. It's quite hard to keep up with. So that's obviously where, you know, we put some webinars together that can hopefully help people. But I think it's just worth every now and again, just check in and see what there is. But I think the review papers, like I mentioned, they're the good places to start. They do all the legwork for you. Look at the review papers, any papers they mention that look of interest, then obviously you can look into them more specifically.
Perfect, great, that's great to know. So we've got a few questions come through from Dave. So Dave has asked, hi Dom, he said, if we are targeting a calcification at 15 millimeters, would you use the 10 or 20 cone or both?
I use both. So for anybody that is not familiar what he's talking about, is the gel pad that is on the system will have a number, and it's basically referring to the millimeters in depth that it travels. So 10 millimeters being a centimeter in depth. So when we talked about that focal zone, if is this Dave Howells by any chance?
It is, yeah.
Hi Dave, I know he's joining us from Jersey. So yeah, the focal zone for the system that he's got is 10 millimeters in height. The middle point, the central point, is that's where your depth is. That's where it's set to. So you're going to have 5 millimeters either side. So you're going to be affecting tissue between 5 millimeters to 15 millimeters. So I hope that makes sense. So if you then use the 20 millimeter gel pad, you're going to be affecting tissue between 15 and 25. And that's just in the main focal zone. You do have some extra areas as well in the -5. I think it's the megapascal area. I think it is -5. I can't remember the exact details, but you do have some effects. But yeah, I'd use both, and you'll definitively be hitting it then.
Okay, great. So I'm going to cover a few more questions from Dave as well. So the next question, where do you target in frozen shoulder?
Where do you target in frozen shoulder? Usually where the patient is complaining of pain or where their restriction is. Let me say, I feel restricted in particularly here. If I can get a pain response, that's where I'd hit. If you've got any radiographic changes as well that looks abnormal, potentially looking around hitting that as well. But I think, you know, I'm quite fortunate that I've got got access to the linear source. So if it's not too much of a pinpoint area, I'll just use the linear probe. So I've got 4.5 centimeters of hitting, and I'll just work around the area. Any points of pain that I get from the patient where they're saying, oh, that replicates the pain that I feel, which is a really important point. That's what you get with focused, is it quite often replicates the patient's pain sensation. I'll stay there for a little bit until that pain eases. Where you can, you want to try and actively or passively move them. So whatever range they have, try and move them in that range. But yeah, where they're experiencing the tightness, where they're reporting the tightness, but where they're reporting the restrictions, I'd aim for that really.
Yeah, perfect. And any evidence for targeting osteocytes in OA, for example, in DIPJ fingers restricting movement?
So osteocyte, I mean, I had this question actually not long back. Is this Dave as well?
Yeah, just covering a few questions.
I'm sure he asked this question before. I'm not entirely sure. The bone area is something that I've only just started reading on really. In terms of, you know, is it on about the sort of, say that again, so is it osteocytes in terms of like reproduction of osteocytes and things?
In OA, so osteoarthritis.
Yeah, so, you know, there's, in terms of like the bone evidence that there is evidence that is stimulating osteocyte and osteoblast and osteoclast reproduction. So it's helping with bone reproduction. When it comes into arthritis, I think the jury's out a little bit on it. I've spoken to a few people about it. My personal thing, I've not treated anybody with arthritis yet because, one, I'm not comfortable with it, and because I haven't seen the evidence to say that it's effective. However, you know, what a lot of people are doing is they're taking the evidence from delayed unions and non-unions research that's out there, which is showing that it's improving bone healing and transferring that across and seeing if they get that result. Now, I know Dave's a doctor, so, you know, he'll be, you know, backed up with that from that aspect. From an insurance perspective, me as a sports therapist, I'll be steering clear as that. So it's something that I'm certainly having a look into, but yeah, there is. If Dave wants the information, then we can get the information around the bone stimulation stuff around arthritis.
Perfect, thanks, Don. And a question from Chris: is there a common conversion between MJ and bar when interpreting the research? I hope I've asked that question right.
Say that again. Sorry. Is there a
common conversion between MJ and bar when interpreting?
Oh, millijoules and right. Okay. Yeah. Yeah. I looked at this actually when I was doing a lot of the research, because when you're looking at radial, they'll quite often put it in bar or megapascals, I think. And in terms of millijoules per millimeter square, I haven't really found a conversion that I can make sense of. And I think the main aspect, if you're trying to compare radial and focused, they are two completely different pressures. You know, focused, depending on who you speak to and depending on which system you're using, can be anywhere between sort of 10 times more powerful, 50 times more powerful. Millijoules per millimeter squared tends to be the measurement that I will go to in terms of from a focus perspective. I know from a radial it's bar. I haven't found a conversion. I've searched it. I have not found a conversion that I say that makes sense, that somebody that's pulled it across. So sorry, I haven't got an answer for that really. But I think if you're comparing bar and millijoules, then I think you might be comparing radial and focused, which I think it's quite difficult though, because they are two individual things, like comparing TechArt therapy and interferential. They both use electronic stimulation, but both at different frequencies and wavelengths. So, you know, it's quite difficult to, in some cases, directly compare.
Yeah, perfect, thanks. So just a couple more then. A question from Michael. In your opinion, can radial shockwave be used for pregnancy patients, even if it's used away from the abdominal area, for example, if it's used on the upper limb?
This is a controversial area. Obviously, if it's away from that area, some people will argue that it's okay. I have always erred on the side of caution. If I can find an alternative in terms of exercise rehabilitation, stretches, and other treatments, I will. I just don't want to risk it. So, I mean, in terms of radial, if it's on the wrist, some people would argue that because it's so localized on the wrist, it's going to bear no impact. Shoulder, I'll be a little bit more cautious of, because I'm getting closer to the vicinity of the central area and around baby. So I don't really want to give a definitive answer on that, because there isn't a definitive answer, in my opinion. I think it's what you deem as clinically appropriate. I've treated pregnant women before, and it's always been with sort of manual techniques, exercise rehabilitation, and that kind of thing. The only time that I've done sort of a treatment with another device was with a lymphatic drainage device that we have on ankles, because she basically twisted. It wasn't swollen ankles from the pregnancy. She actually just twisted her ankle. First trimester, that was the only one that I've used. Yeah.
Great. I think that's fair.
Yeah, I'd use a clinical experience. Some people will probably say, yeah, if you're away from the area, like wrist, elbow, then probably no problem. But I'd say it's just like, I know you can look at the International Society of Medical Shockwave Therapy, the ISMST. They've got their list of contraindications, indications, and advices there. If you've got a radial system and it's the radial system, if you know the company, I'd give them a call as well and just say, like, I want to use it on pregnant patients. What do you say?
Yeah, good advice. Absolutely. And then, so the final question, quite a nice one to sort of finish on. What main piece of advice would you give when clinicians are trying to digest the research papers and then using it within their practice? So that main bit of advice.
Well, I mean, if everybody on here is a clinician, then you'll know how to sort of critically analyse papers. One of the things that is a bit of a bugbear of mine is that you just look at the conclusion and you just take that as right. You know, that it didn't work for that, or it did work for that. Quite often, if I see a paper where the conclusion is not or hasn't been very positive, then I will ask why. What's different to this paper compared to the papers that have said it has been positive? It means it's come up with a negative result. Vice versa. If you're seeing a lot of papers that are showing, like, you know, the non-calcific tendinopathy shoulders, you know, pretty much saying it's not very conclusive, and you see a paper that says it's very, very positive, again, I'll be going, oh, okay, that's gone against the grain. Why? And I think it's just when you see something that's gone a little bit against the grain, and against what you've heard other people say and what you've seen on webinars and people's websites and blogs and all that kind of thing, and you see a bit of research, or you see something that's going, oh, actually, that's, you know, that's opposite to what I know, I just have a look and just sort of think, oh, why? Compare it to what you've seen before. But yeah, you know, everybody will know how to read papers. But I think it's just, you know, those are the main things. Is if something is gone against the grain, it's just asking why is that gone against the grain.
Great, perfect. And Dom, are you up for doing another research webinar on the lower limb then, hopefully in a couple of months?
Yeah, well, you know, lockdowns have given us a chance to actually read the papers and pull everything together. So, you know, I hope everybody keeping busy over lockdown. I think it's been quite good that some clinics have been able to stay open, which is good. But yeah, no, it's like the first lockdown gave us a really good opportunity to read some research. So I have the content.
Good.
Tested in lower limb, we can do that as well. That's not a problem.
Great, we'll look forward to that then.
All right.
All the questions there. So thank you everyone for joining us this evening. We hope you enjoyed the session. And thanks, Dom, for your time and obviously your expertise on this. So thank you very much. So following this, you'll receive a survey along with the link to the webinar recording. So we would really appreciate just any feedback and suggestions for some future webinars. So a follow on from this webinar will be a showcase of 2 real-life patient cases of particular wrist and hand indications. So that's going to be on the 10th of February. So make sure you check it out. You have a chance to win a small multi-curve port grip tool by guessing one of the indications John will be covering on this webinar. So make sure you head to the event page on our website where you can watch the before and after video for a clue, and then you can submit your guess on the registration form. So looking forward to seeing everyone's guesses on that one. And as always, you can contact us at any time if you're interested in any of our technologies or events, and you can reach us on info@physicquip.com. So thank you again for joining us, and I hope you all have a lovely evening.
Thanks.